Good evening, everyone. I am presenting the case pancreatitis in pregnancy. The patient was admitted under medicine 3. She is under OG3 and the moderator will be Dr. Anuja from OG3. We'll go through the case presentation, differential diagnosis, background, how to diagnose pancreatitis in pregnancy, how to assess severity, and what is the management. Starting with the case presentation. Presenting Mrs. L, 20-year-old primey, who was booked outside at 31 plus 6 weeks of gestation. She has presented from Kadapa with history of abdominal pain for 5 days and vomiting for 5 days. Abdominal pain was epigastric, continuous and severe. It was radiating to the back and increased after meals, was relieved on analgesics. She had 5 to 6 episodes of vomiting per day, which were non-bilious and non-blood stain. She did not have any fever, no loose stools, no jaundice. She did not have any decreased urine output prior to presentation. She has significant family history of her brother being diagnosed to have diabetes early on in his life. No history of high cholesterol in the family, early coronary artery disease, or sudden cardiac arrest in the family. She is unsure of the history of diabetes in her grandparents, but she knows that her parents did not have diabetes. She is a primey. Her last menstrual period was on 26th of February, regular cycles. She was told to have high sugars during her antenatal checkup. In the first trimester itself, she was noted to have AC of 142 and PC of 175, for which she was started on metformin and medical nutrition therapy. 2 months later, because she had persistently high sugars, she was started on insulin, and prior to presentation here, she was on Mixtard. Since she was diagnosed in the first trimester itself, she is a pre-gestational or overt diabetic. Currently on general examination, her pulse rate was 120, she is tachycardic, blood pressure was 100 by 70, respiratory rate was 33, she is tachypneic, and she was taking short, shallow breaths. Acidotic breathing was present. She was afebrile at the time of presentation, JVP was not elevated. Her BMI is 18.2, so she is a lean person, she is not obese. She did not have any pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. She was mildly dehydrated. She had no features of malabsorption. We looked for bitoid spots, features of vitamin K and vitamin D deficiency, which she did not have. She did not have any features of xanthelasma, tendon xanthomas, no acanthosis, no features of lipodystrophy. We were trying to look for features of hypertriglyceridemia and insulin resistance, as well as other causes for young diabetes. On systemic examination, her abdomen, she had mild epigastric tenderness, no rebound or guarding. Bowel sounds were present, but they were sluggish. Liver and spleen were not palpable. She had a 32 weeks gestation uterus palpable, cephalic presentation. There were no contractions at the time of presentation. Fetal heart and fetal movement were present. Other system examination was normal. Because she had presented with an acute history of vomiting and epigastric pain, as well as she is a young diabetic, the first differential we considered was diabetic ketoacidosis. Other differentials were acute pancreatitis, cholecystitis, choledocholithiasis, and less likely peptic ulcer disease or mesenteric ischemia. We went ahead with investigations. The first investigation, arterial blood gas analysis in casualty, showed a high anion gap metabolic acidosis. Her pH was low, 7.28, bicarb was low, 9.4, and anion gap was high, 18. Her GRBS at admission was 400 and urine ketones were 3 plus. Therefore, she had a diabetic ketoacidosis at the time of admission. Further investigations revealed that her hemoglobin was 13.4, whereas her baseline was only 8.8. So she was hemoconcentrated at the time of presentation. Total counts and platelets were normal. Amylase lipase was significantly elevated, 508 amylase and lipase 1565. She did not have any acute kidney injury at the time of presentation. Liver function tests were grossly normal. Urine routine was normal. Ultrasound abdomen was done, which showed pancreas was mildly bulky with heterogeneous echo texture. There was no peripancreatic collection, no gallstones, and common bile duct was not dilated. This we did to look for any pancreatic collection and gallstone as an etiology for pancreatitis. So by the end of this, we were sure that her pancreatic enzymes, amylase lipase are elevated. The Ultrasound is showing heterogeneous ecotexture of pancreas, and she had a diabetic ketoacidosis. We wanted to work up for the etiology for the pancreatitis. Since ultrasound did not show any gallstones, we sent electrolytes, calcium, phosphorus, which were normal, and lipid profile was sent, which showed high triglycerides of 573 and LDL 149. We also did a young diabetic workup because she is a lean and young diabetic. Her HbA1c was elevated. GAD and islet cell antibodies were negative. C-peptide sent fasting was normal. 2 hours was planned on OPD basis, which we are going to follow up. At the end of history and examination, the diagnosis was of an acute pancreatitis, probable hypertriglyceridemia associated with diabetic ketoacidosis and young onset diabetes. She is a primary at 31 plus 6 weeks of gestation. We initially considered hypertriglyceridemia, but whether this is really the cause, I will come to later. Discussion about acute pancreatitis in pregnancy. The incidence of acute pancreatitis is variable. It varies from 1 per 1000 to 1 in 30,000 live births. Incidence is not higher in pregnant people. It is the same as non-pregnant individuals. And the causes are also similar in non-pregnant as well as pregnant. The most common cause in 65% people is gallstone, 10% alcohol, 10% hypertriglyceridemia, and 15% other causes. In an observational study which was done in Dallas, Texas, 47 pregnant women with pancreatitis were studied. More common pancreatitis was seen in multiparous women and in women with advancing age. This was considered because they thought that gallstones are more common in people with advancing age, which was the most common cause. Across trimesters, they noted that highest incidence was in the third trimester, 50%, followed by early postpartum period, 38%, and very rarely pancreatitis occurred in the first and second trimester. What does pancreatitis do to the mother? So in the mother, the complications are quite similar to a non-pregnant person, which are local complications like pancreatic necrosis, pancreatic collection or pseudocyst, systemic complications like shock or organ failure, and regional complications like gastric outlet obstruction, splenic and portal vein thrombosis. However, in a pregnant lady, effects on fetus have to be also considered. So on the fetus, it can cause preterm birth in 25 to 37% and perinatal mortality in up to 3% of the children. Severity of pancreatitis, it does not vary from non-pregnant population. More or less, 80% have only mild pancreatitis, whereas 20% develop a moderate to severe illness. The mortality for severe pancreatitis is up to 30%, whereas in mild, it's only 1 to 2%. Higher mortality is noted with hypertriglyceridemia associated pancreatitis. How to diagnose pancreatitis in pregnant women? The diagnostic criteria does not change just because a lady is pregnant. Diagnostic criteria is the same. 2 out of 3 of the following should be present. That is symptom of severe epigastric pain radiating to the back associated with nausea, vomiting and decreased bowel movement. Lab evaluation showing amylase lipase more than 3 times the upper limit of normal, and imaging showing features of pancreatitis, either interstitial edema or necrotizing features. The severity of pancreatitis is based on Atlanta grading, where our patient had mild pancreatitis with no organ failure and no local or systemic complications. Indicators of poor prognosis for pancreatitis are obese people with BMI more than 30, more than or equal to 2 SIRS features, laboratory evaluation showing BUN more than 33, hematocrit more than 44 and rising, glucose more than 190, and imaging features of pulmonary infiltrates or pancreatic collection. Our patient did have high sugars at the time of admission, but other features were absent. What is the management of pancreatitis? The most important management is fluids. Why is fluids important? Because vomiting, third spacing, respiratory loss, and poor intake all lead to dehydration, which finally leads to pancreatic necrosis. So early resuscitation is necessary to prevent pancreatic necrosis. Which fluid do we use? Usually crystalloids. We use at 5 to 10 ml per kg per hour and give 3 to 4 liters in the first 72 hours. How to monitor whether adequate fluids have been given? The parameters are clinically heart rate less than 120, Mean arterial pressure should be maintained at 65 to 85. Urine output should be more than 0.5 to 1 ml per kg per hour, and the packed cell volume should remain between 33 to 44. If a patient is admitted in ICU, additional parameters like IVC diameter or B lines in the lung can be looked for. Since we have chosen crystalloid, we should also know which crystalloid to use, ringer lactate or normal saline. This has been an ongoing debate. However, an RCT which was done in patients with acute pancreatitis showed that ringer lactate had lesser chance of progression of SIRS and had more reduction of CRT. However, further studies which came after that refuted this finding. So this is a conditional recommendation to use RL over NS. Other aspects of management are analgesia, which is paracetamol and opioids. In pregnancy, these are class C drugs. And enteral feeding, which is early enteral feeding, orally tolerated, is preferred over TPN or NJ or NG feeds. There is no role of antibiotics unless there is a proven infection. The last part of treatment of pancreatitis is modification of risk factors. So in this patient, there was definitely some hyperlipidemia. We'll go through the management of hyperlipidemia and see if this was the only cause for pancreatitis in our patient in the end. Anyway, pregnancy is a dyslipidemic state. Because of high estrogens, there is increased output of VLDL and triglyceride from the liver, and because of increased activity of cholesterol esterase transferase protein, there is increased conversion of VLDL and triglyceride to LDL. Further, there is decreased lipoprotein lipase action. Therefore, the breakdown of VLDL and LDL is decreased. So, the serum levels of VLDL and LDL rise. There are certain factors which enhance this dyslipidemia. These are excessive weight gain, diabetes, alcohol consumption, drugs, and certain genetic abnormalities. In our patient, diabetes was the probable factor which was worsening the existing dyslipidemia. What to do? What are the options in a patient who has dyslipidemia? First is diet. Second is dietary supplementation like medium chain triglyceride, omega-3 fatty acid or niacin. Third is insulin. Fourth is fibrates. And last is plasma exchange or PLEX. In diet, we advise the patient to take less than 20% calories from fat. However, the problem is compliance, and very rarely there is risk of impaired fetal brain and visual development if essential fatty acids are deficient. This is a very rare finding seen in less than 2% people. The target triglyceride is less than 800. Other dietary additions which we can give are omega-3 fatty acid and medium chain triglyceride. In pregnancy, there are mostly case reports only which are supporting this. There is only one RCT for omega-3 fatty acid, and they have noted that it is a category C drug where in the mother the side effect is only unpleasant odor and fetus is unlikely to have any side effects. The medication which we can use are fibrates and insulin. Both are based only on case reports. There are no randomized controlled trials. Fibrates commonly used are gemfibrozil, fenofibrate, and there are no maternal or fetal complications. This is also a category C drug, and insulin is also safe given at 0.1 unit per kg unless there is hyperglycemia. This, however, cannot be used. What about delivery? If we perform delivery, 10 to 20% decrease in triglyceride happens within the next 24 hours. However, maternal and fetal condition has to be taken into consideration, especially if we are delivering the lady preterm. There is no specific guideline on the mode of delivery. However, normal is preferred over LSCS. In our patient, she was given fluid resuscitation. Insulin was given at fixed dose to control sugars as IV infusion. For pain, paracetamol was used. She did not require opioids. There were no antibiotics given. For etiologic workup, there is high triglyceride, but usually triglycerides more than 700 to 1000 only cause pancreatitis. So in our patient, we thought that the triglycerides were slightly higher than expected because of the underlying diabetes. She was advised low-fat, low-cholesterol diet. Sugars at discharge were controlled with basal bolus regimen of insulin, and she had no complications related to pancreatitis, whether local, systemic, or regional. At discharge, we advised her, other than the diet and insulin administration, to maintain a 4-point profile and titrate insulin according to sugars. We also explained to her that there is increased rate of preterm birth and there is also significant mortality despite the complete treatment. There's no role of early delivery and she was in ketosis at the time of admission, so we did not deliver her at that time. We advised her to monitor fetal movements and review on OPD basis. The learning points were pancreatitis in pregnancy management and the implications of the same to mother and baby. Thank you.